Good day to wherever you are, and thank you for giving your valuable time to this session. I am 𝗞𝗲𝗍 𝗟𝗲, Clinical and Product Director at Debridement Medical. My work takes me to wound clinics across many countries, and every stop teaches me something practical that I bring back to share. Today, we will walk step by step through how a diabetic foot ulcer, or DFU, can move from stalled, stubborn surface to healthy closure. Here's our simple roadmap, so everyone can relax. I will speak for roughly 40 minutes in a clear, steady rhythm for a global audience. A couple of short clips will show Debridement in action. Also, a live chat stays open the entire time, so drop your questions whenever they pop up. We will answer as many as we can at the end, and anything we miss, we will follow up by email. Slides and a one-page summary will reach your inbox shortly after we finish. We will begin with the basics of how skin repairs itself, because knowing the healthy path makes it easier to spot what goes wrong. We will look at biofilm, the hidden city that locks wounds in a chronic state. We will use the T.I.M.E framework to keep care balanced and simple. Then we will zoom in on diabetic foot ulcers, why they happen, why they stall, and which practical steps help them move forward. From there, we will dive into the role of Debridement as a topical desiccating agent that helps clear biofilm fast. You will see a short animation, a video of the effect of Debridement on bacteria under a microscope and the application on a real wound. We will close with a case story confirmed by fluorescence imaging, then discuss our latest publication of 67 patients with DFUs, and finish with the 5 key takeaways in a short Q&A in the chat. Please take a comfortable breath, roll your shoulders once, and let us begin. Think of a healthy skin as a living city wall. It keeps precious body water inside, shields nerves and vessels, and blocks out threats like sharp edges or germs. When this wall is broken, the body launches a repair project that is faster and better organized than any human construction team. The 4 phases of repair are easy to remember once you picture the job site. First comes hemostasis. Blood vessels narrow and platelets form a plug. The clot is not only a patch, it is also a chemical broadcast that calls for help. If you have ever seen a scab form within minutes, you've seen hemostasis at work. Next is inflammation. The cleanup crews arrive. Neutrophils and macrophages remove loose debris and carry away early invaders and release signals that guide what comes next. Warmth and mild swelling tells us this crew is active. Short, well-controlled inflammation is helpful. When it lingers, troubles begins. Then we reach proliferation, and this is the building phase. Tiny new blood vessels sprout to bring oxygen and nutrients. Fibroblasts weave collagen, and a red-pink layer called granulation tissue fills the gaps. From the edges, new skin cells, they crawl inward and to cover the surface. So think of it like filling a hole in a wall with fresh plaster and then drawing a thin coat of paint across it. Finally comes remodeling. Collagen fibers line up, the strength improves, and color shifts towards the normal skin tone. Nerves reconnect slowly to restore sensation. And this polishing phase can continue for months after the wound looks closed. A tidy surgical line with edges side by side usually heals in a primary intent, but when it's a bigger and contaminated or uneven wound, this heals by a secondary intent. First, the gap fills with granulation and the surfaces close. Why do some wounds become chronic then? When cleanup lingers and building stalls, an acute wound crosses into a chronic wound. 3 big factors show up again and again. devitalized tissue, high bacterial burden, and biofilm. Each steals oxygen and nutrients, each blocks healthy cell migration, and each keeps inflammation smoldering. Every week that a wound stays open increases pain, cost, infection risks, and patient frustration. This is why the first moves we make during cleanup often decide the whole journey. How this picture of an orderly construction in your mind, and in a moment we will meet the villain crew that loves to sabotage it, the biofilm. To make these phases more concrete, picture a small cut in your forearm. In the first hour, the clot organizes and stops the leak. Over the next day, the area looks a bit puffy and as the immune cells do their sweep. In a few days, a fragile red carpet fills the gap, and a week later the surface is sealed with new skin. Months later, the scar line fades and the script, and this is when the script, when biology has what it needs, right? So what does biology need to keep the script moving? 3 basics repeat across all wounds: oxygen, moisture, and a clean base. Oxygen arrives with blood flow. Moisture keeps migrating cells happy, and a clean base means that the surface is free of crust and slime that can block cell movement. These 3 basics show up again when we talk about time. And they are the reason we care so much about early debridement. 2 small clarifications help avoid confusion in daily notes. First, normal inflammation is not infection. Mild warmth and swelling in the first days can be a sign of helpful cleanup, not a reason to start broad antibiotics. Second, a scab is a natural cover, but a thick, dry crust is not always your friend. If it prevents cells from moving or trap fluid, it can slow healing. That is why modern care nudges wounds towards a moist and not scabbed surface. You might also hear the term wound contraction. In many open wounds, myofibroblasts help pull the edges inward like a drawstring. It is a normal part of the proliferation phase. In tight areas like the plantar foot, however, contraction has limits. Which is why offloading and edge care remain important even when granulation is strong. Finally, remember that remodeling can last long after closure. Scar tissue has a different architecture than unwounded skin. We set expectations gently with patients, as the goal is safe closure first. Then strength and flexibility over time. A patient who understands this is less likely to reopen a site with early overuse and more likely to protect their successes. Then we'll move on to biofilms. Imagine a group of campers who reach a lakeside, build cabins, raise fences, and settle for the long term. Germs act in the same way. They attach to a wound surface, glue themselves together, and build a slimy roof over the colony. That roof is called biofilm. Biofilm is common in chronic wounds. In other words, literature says the majority of chronic wounds contain biofilm, roughly 60 to 80%. Inside the slime, bacteria cooperate and communicate. They share nutrients and sometimes even share genes, including ones that make them tougher to treat. Bacteria living in the biofilm can be 10 to 1,000 times more tolerant of antibiotics than the same bacteria floating freely in fluid. The immune system also struggles to reach them. Picture a thick shield wall. Antibiotics seep through slowly, and immune cells run as if through mud. Meanwhile, the colony behind the wall keeps throwing out toxins and enzymes that irritate the tissue. Another detail matters: water. Biofilm is largely water, held in a mash of polysaccharides, proteins, and DNA. You can think of it as a sticky jelly. Remove water fast and the structure collapses like drying paint. That collapse unlocks access to the wound bed beneath. Clinically, what does biofilm do? Well, it keeps inflammation alive, so the wound never moves smoothly into the building phase. It promotes recurring infection, so you see a cycle of temporary improvement followed by a setback. It damages nearby tissue, feeding more debris back to the bacteria, and it becomes a closed loop. Biofilm, inflammation, tissue death, more bacteria, stronger biofilm. And so on and so on. So how do we break the loop? With debridement. Sharp tools can lift slough and dead tissue. Antimicrobial dressings can help bacterial multiplication. But biofilm can reform within days if we do not clear it thoroughly. This is where Debridement comes in. It follows the simple rule we just mentioned. Remove water rapidly from the biofilm layers and it breaks apart. In practice, a 60-second contact is enough to desiccate soft necrotic tissue and biofilm, exposing bacteria so we can rinse and wipe them away. We will look at the process in detail shortly. Before we move on, one more picture. If a healthy healing wound is a clear running stream, a chronic wound is a stagnant pond. It looks still on the surface, but under the film, it is crowded and unhappy. Our job is to drain that pond, clear the muck, and let fresh water flow again. Let us unpack the biofilm shield a bit more so you can picture why it resists that care. The slime matrix slows diffusion. Antibiotics that reach the surface become diluted before they get to the core. Some bacteria in the inner layers grow slowly, which further reduces the impact of antibiotics that target active division. The community also creates tiny gradients of pH and oxygen that favor certain species and make life harder for host cells. All of this means the colony can sit quietly even when we think we have done enough. Because biofilm is mostly water, often described as up to 97%, strategies that dehydrate the matrix make sense. Think of a wet paint film on a window. If you pull the moisture quickly, the film cracks and lifts. That is simply a physical idea behind desiccation-based debridement. It's not magic, it's physics used for biology. In practice, patients feel the presence of biofilm long before we name it. They describe a wound that smells, drains more than expected, and looks slimy again after a few days after cleaning. You may see islands of slough stuck to the base that do not budge with gentle wiping. You might also notice that the edges look dull and rolled rather than sharp and mobile. These are the scenes where the decisive, thorough biofilm break is worth the effort. A quick word on teamwork. Biofilm management is not a one-person show. The person doing debridement primes the surface. The person selecting dressings keeps moisture in balance, and the person educating the patient reduces new trauma and contamination. When the whole team pulls in the same direction, the time between visits increases and closure arrives sooner. That brings us to the time principle. To keep care balanced at the bedside, wound teams use a checklist called T.I.M.E. Think of it as a 4-string on a guitar, and for healing music, each need the right tension. T means tissue. Remove slough, eschar, and biofilm. A clean stage welcomes active cell migration. If you only change dressings and avoid debridement, you often end up changing dressings and have the same problem week after week. I means inflammation or infection. Warmth, swelling, odor, unexpected pain, or a plateau in healing can point to bioburden. Calm the heat by cleaning thoroughly, using smart dressings and starting systemic therapy when deeper signs are present. When you disrupt biofilm well, you usually lower inflammation along the way. M means moisture balance. Wounds prefer a moist environment. Too wet macerates the edges. Too dry stalls cell movement. Modern dressings help us fine-tune the middle ground, whether we need to absorb or donate moisture. E means edge. Healthy edges advance like a zipper. If edges are rolled or stuck, do revisit the T, the I, and the M and adjust. I like to invite teams to recite time softly while removing each old dressing, and it keeps thinking clear and the notes simple. Let us apply time to a typical plantar DFU so you can hear the rhythm. Tissue. Start by taking down callus that overhangs the crater. After callus, address slough and suspected biofilm. Anything that looks stringy, slimy, or gray and does not wipe clean deserves extra attention. Inflammation or infection. Look for soft tissue signs like warmth and tenderness, but remember neuropathy can mute pain. Sniff for odor after cleaning, not before. And do avoid reflex antibiotics for every stalled ulcer. They help when infection is real. They do not substitute for debridement when the barrier is biofilm. Moisture. If the dressing comes off soaked and the edges look soggy and pale, you need more absorption. If the base looks parched and sheet-like, donate moisture with a hydrogel or moist contact layer and reevaluate at every next change. Edge. If the border is rolled under, you can gently refresh it once your base is clean. Chronic wounds can come from many different causes, but they all share one frustrating trait: they take far too long to heal. We see pressure ulcers when constant pressure cuts off blood flow, often over bony points. Venous leg ulcers appear when poor vein function causes swelling and over time the skin gives way. Arterial ulcers happen when reduced blood flow starves the tissue of oxygen and nutrients. And then there are post-traumatic or post-surgical wounds that stall because dead tissue or heavy bacterial load just won't clear. For this session, we're going to zoom in on diabetic foot ulcers. A particularly challenging mix of nerve changes, poor circulation, repeated pressure, and high risk of biofilm. Now, why focus here? Because diabetic foot ulcers bring together almost every obstacle we've just mentioned. They're common, they're complex, and they demand a very deliberate approach if we want to avoid the worst outcomes. So let's take a closer look. What makes them so difficult? And what can we do about it? A diabetic foot ulcer, or DFU, is more than just a sore on the foot. It is the visible tip of a much deeper iceberg. Iceberg shaped by changes in nerves, blood vessels, and immune function, and widened over time by repeated pressure and small injuries that go unnoticed. On the surface, you can see an open wound. Underneath, there is a network of contributing problems that have been there building for years. So let's start with those inner forces and the changes happening inside the body. First, neuropathy. long-term high blood sugar damages nerves. Sensory nerves stop sending clear pain or pressure signals, so the normal alarm system is just gone. A small pebble in the shoe, a tight seam in the sock, or hours of standing on a hard floor can all cause harm without the person realizing it. Motor neuropathy changes the way muscles work together, altering foot shape and creating new pressure points. Autonomic neuropathy dries the skin, making it more fragile and prone to cracks that invite infection. Next, microvascular changes. High glucose affects small blood vessels, reducing oxygen and nutrient delivery to tissues. This slows the division of fibroblasts and weakens collagen. It also delays the body's ability to build strong repair tissue. Even if the heart and large arteries are healthy, these microscopic vessels can quietly limit healing capacity. And then there's the immune drift. Diabetes can blunt the immune response. Chemotaxis slows, phagocytosis becomes less efficient, and bacteria gain valuable time and to multiply and organize into colonies. This is one reason DFUs are so prone to infection and why those infections can become severe very quickly. Now, the outer forces. The daily physical stresses. Pressure and shear are the big ones. Tight footwear, rigid toe joints, callus buildup, or changes in gait can all concentrate forces on a small area of the foot step after step. Over time, skin breaks down, reduces as redness, then blisters, and finally opens an ulcer. Foot deformities like claw toe or Charcot collapse or fat pad migration shift how weight is distributed. A single square centimeter might end up carrying the load that should have been spread over 10 times that area. That overload accelerates damage. So what does this mean in the clinic? It means we have to think in layers. The wound itself is one layer. The underlying disease processes are another. And the patient's daily habits form another layer, or third layer. If we only treat the surface without addressing the others, we risk going in circles. Here's a practical first step that fit into any DFU assessment. Glucose optimization. An HbA1c in a safer range supports nerve and vessel health and lowers infection risk. Even small improvements make a difference. Offloading. This is a treatment, not an optional accessory. Total contact casts, removable walkers, or well-designed custom shoes spread pressure evenly. Every hour of the wound is an hour gained for healing. Vascular screening. Palpate pulses, check ankle brachial index, toe pressures, and Doppler waveforms. If the numbers show poor flow, involve vascular colleagues early. No dressing or topical product can overcome critical ischemia. Daily skin checks. Encourage the use of mirrors, smartphone photos, or help from family to spot early color changes. Often, redness appears before the skin actually breaks down. Nutrition. So proteins, vitamin C, and zinc support collagen synthesis and cell division. A dietitian guidance can speed repair. Now fitting this into the T.I.M.E framework. Tissue remove callus, slough, and devitalized material to expose the healthy wound bed. Inflammation or infection, watch for spreading redness, swelling, or systemic signs, and treat infection specifically and avoid unnecessary antibiotics. Moisture, keep the wound moist but not too soggy, and adapt dressing choice to changes in exudate. Edge, refresh the rolled and stagnant edges once the base is clean to encourage the migration. Now, even with all these measures in place, many DFUs still stall. You've already heard earlier in this session about one of the major culprits, biofilm. We won't go through the full explanation again, but we know that if it's not removed thoroughly, it can re-establish itself in just a few days. And then keeping the wound in a chronic state. And here's the key point. If we want to change the healing trajectory, we have to break through that barrier. Quickly, completely, and in a way that protects the surrounding healthy skin. In the next section, we're going to look at a method that can do exactly that in just about 60 seconds. So, what is Debridement? It's a single-use topical acidic gel designed for chemical debridement. When it comes into contact with water, in devitalized tissue and biofilm, it triggers a strong desiccating effect. This rapid dehydration collapses the biofilm structure and loosens soft necrotic tissue, instantly exposing embedded bacteria so they can be rinsed and wiped away. Applied correctly, it works selectively, targeting unhealthy tissue while leaving surrounding healthy tissue intact. Let's have a look at this animated video explaining the mode of action of Debridement. Free-floating bacteria will form a biofilm. We discussed what biofilm is. The protective layer for bacteria in a chronic wound. It can grow and mature in half a day. The water, sugars, and proteins of the biofilm are products by those bacteria. Then Debridement comes in to disrupt it all. The red gel is spread on the wound and immediately starts a dehydrating process. When we zoom in, we see that Debridement binds the water molecules and releases an energy burst. This energy is needed to further disrupt the biofilm structure. And it dehydrates the biofilm bacteria. As a result, the wound bed surface is changed into a darker desiccated material. Now, we've seen the process in animation, but what does it look like under a microscope? Let's watch a microscopic video showing how just a single drop of Debridement disrupts bacterial structures. Here we see a live feed of a Salmonella bacterial environment. The Salmonella bacteria is a particularly vibrant one and was therefore chosen for this experiment. As you saw a wave hit the culture, the movement of the bacteria stops immediately. We repeat the video to show you once more the happy wiggling bacteria that stop moving once the wave of Debridement hits. And then, as it's such a fast action, we show it once more for you who has missed it the first 2 times. And this is not just theory. It's supported by some strong laboratory evidence. In a peer-reviewed article published in the International Journal of Molecular Sciences by Schwarzer et al. In 2021, Debridement was tested on multiple in vitro biofilm models including Pseudomonas aeruginosa and Staphylococcus aureus. A single 30-second application achieved complete eradication of viable bacteria in every model. Have a look at the picture on the right and on the pictures on the left. And on the pictures on the left, you see all these small dots. They are the bacteria. On the picture on the right, you see that they are all gone, and right after a single application. Now, that's the lab. How does this immediate eradication translate to real life on a real diabetic foot ulcer? Let's have a look at case 59. This patient is a 64-year-old male, presented with a chronic post-surgical ulcer at a toe amputation site caused by ischemia and gangrene. The wound has been open for 16 weeks, and a single 60-second Debridement application was performed with molecular light imaging before and after treatment. Molecular light is a wound diagnosis instrument that uses UV light to see bacteria. Pre-treatment images show heavy bacterial load, particularly red fluorescence, the kind that is notoriously hard to remove. Post-treatment, molecular light imaging confirmed a drastic bacterial reduction. Over the next month, with standard dressing and offloading, the wound progressed rapidly. 75% epithelialization and full granulation tissue within 4 weeks. By follow-up, reepithelialization was over 90% with no signs of reinfection and no need for additional Debridement treatments. This case highlights exactly what we aim for: fast, thorough removal of biofilm and devitalized tissue, giving the wound a clean slate so the body and our standard of care can finish the job. So far, we've seen Debridement in action in the lab under the microscope on biofilm models and in an individual case. But now let's bring it into the clinic. What does the application look like, step by step, in real life? Let's watch together. Now, beyond individual cases, we have growing real-world evidence. In the September edition of the Journal of Wound Care this year, a retrospective case series was published focusing exclusively on diabetic foot ulcers treated with Debridement. This study followed 67 patients between 2020 and 2023 under a compassionate use protocol, all of whom had chronic DFUs that had not responded to the standard of care. These were high-risk patients with a mean ulcer size of over 33 centimeters square, and the average ulcer age at the time of treatment was even more than 14 weeks. Many had already been considered for surgical intervention, and Debridement was used as a final attempt to avoid amputation. Well, the result speaks for themselves. (88.1% of the patients achieved full granulation, with a mean time of only 44.3 days. 85.1% reached full, complete rehabilitation. And not a single adverse event was actually reported. None of the patients required antibiotics for their ulcer during the evaluation period, but most importantly, the mean number of applications was just 1.2, meaning that the vast majority of these wounds responded to a single 60-second procedure. When you compare these outcomes to typical DFU healing rates in similar high-risk populations, often between 50 to 75% for granulation and even lower for closure, the difference is clear. For clinicians, this means a faster progress, fewer repeated debridements, and a more efficient use of time and resources. This study adds to the growing body of evidence that Debridement can not only disrupt biofilm instantly, but also translate that effect into a meaningful, sustained healing in some of the most challenging diabetic foot ulcers. Well, we've covered a full journey today. And here are 5 bright signposts to keep. Healthy skin repairs best on a clean, moist, well-perfused stage. Biofilm hides bacteria and keeps wounds inflamed, yet it collapses when water is fast removed. The time framework keeps wound care balanced and simple at the bedside. Tissue, inflammation or infection, moisture, edge. Diabetic foot ulcers demand inner control of glucose and blood flow, plus outer relief of pressure. Offloading is treatment, not an accessory. Debridement can rapidly clear biofilm and soft necrosis in a 60-second application, gives your dressings and your patient's biology a fair chance to work. Well, the chat has been open for your questions, and any thoughts, we will walk through them together later on. You can request a demonstration if you would like to experience Debridement in your clinic or study lab. Use the link in the chat or visit the Debridement Medical website and select Request a Demonstration. Our team will arrange a hands-on session at a time that suits you. Thank you for your attention. Keep the curiosity high, share this knowledge with your teams, and may your patients experience the comfort of faster healing. Enjoy the rest of your day. For next steps, decide on one change you can make this week. Maybe it's adding a short timeline in every note. Maybe it's building a tiny checklist for your room so rinses and gauzes are always ready. Maybe it's a couple of minute shoot check lessons you add to every DFU visit. Small repeatable moves will turn into big results over weeks. I am grateful you spent your time here. And if you test Debridement in your setting, do tell us what you see. Real-world stories help teams everywhere learn faster. Thank you, and see you at the next webinar.